Another one done.
Yes. Done and done.
Woo!
Done and done.
Like I said, that was brain tiring.
It was a tough one today.
Yeah, today was a tough one.
Yeah. Hey, welcome to BodyPlus. I'm Dr. Oliver Sanchez, and I'm joined today by my co-host, Dr. Zoe Fasoulakis.
We are both chiropractors here in Vancouver, BC, and this is a show where we break everything down to do with your body, movement, injury, performance, and recovery, and also everything in between.
Whether you're dealing with something that just won't go away, trying to get more out of your training, or just want to understand how your body actually works, this is for you.
We keep things real, practical, and easy to understand. No jargon, no fluff, just real conversations and clear answers. So whether you're new here or coming back, we're glad you're here.
This is BodyPlus. No more, move better. Today's episode, the shoulder, one of the most complex joints in the human body, and honestly, one of the most misunderstood.
We see shoulder issues in the clinic all the time. Everything from people who can't lift their arm above their head to athletes who've been dealing with a nagging ache for years and just keep pushing through it.
So today we're breaking down the top 3 shoulder injuries we see most often: frozen shoulder, rotator cuff injuries, and calcific tendinitis. What they actually are, how we assess and treat them, and what recovery looks like. If your shoulder has been giving you trouble, this one's for you. Let's get into it. Before we get into specific injuries, the shoulder is one of the most complex joints in the body. Can you give us a plain language picture of what's actually going on structurally? What makes it so different from, say, a hip or a knee?
Yeah, okay. So yes, it is a bit different structurally compared to your hip and the knee, but just to break it down, so the shoulder itself is like a ball and socket joint. So that just means there's one part of the joint that's like a cup and the other part that is like a rounded surface, so ball and socket. What makes the shoulder unique is that this ball and socket is really mismatched. So they often compare it to like a golf ball being the ball and then your tee being the socket. So it's a really big ball on a small surface, which makes it really mobile. So there's a lot of mobility with the shoulder compared to your knee or your hip, which are a lot more stable. And so therefore, the increased mobility, so it's really able to move a lot, it compensates by being a lot more vulnerable stability-wise. And so that is why it's kind of more vulnerable to injuries, because those structures around it, like your muscles or your ligaments, have to work overtime to provide that stability there for how much it can move. So Oliver, you see shoulder complaints a lot in the office, right?
Yeah.
So through your experience working, how would you describe like your typical shoulder person who comes in? Think about maybe like their age, what they do, stuff like that.
Well, I think with shoulder injuries, you definitely see them in a lot of different populations and different activity types. So a lot of people think that most of the injuries are going to come just from your active population, but you can also get in from people that are sitting at the computer for extended periods of time.
Yeah.
So, when it comes to the athletic population, you're definitely going to see it in overhead athletes. So people that are doing CrossFit, for example, now that we've done high rocks activities, because you are pulling from above for some things.
Wall balls.
Wall balls is another one that can definitely affect it. So we're definitely seeing that quite a bit. And then sports-specific stuff, some volleyball players I've definitely seen with shoulder injuries. And also pitchers is quite a big one as well.
Blue Jays,
Yes,
baseball.
Definitely some baseball stuff for sure. Especially with my kids playing Little League, we definitely see the shoulder injuries coming up now that they're throwing quite a bit more.
Yep.
Even though it is, regulated and controlled quite well, but it's still going to happen. And then on the other side, we're going to see the people that are deconditioned, that aren't using the shoulders very often. So, people working at the computer for long periods of time, spending a lot of time sitting or playing video games. That'll definitely weaken the rotator cuff, which, as you just said, is one of the big stabilizers of the shoulder.
Yep.
So if that's not functioning well, that's going to potentially lead to injuries whenever they do decide to do any type of activity. And in that case, it doesn't have to be any major activity. It could just be, picking up some groceries or doing some
basic everyday things that they wouldn't think are like a big strenuous thing.
Exactly.
Right?
But as soon as they move, that muscle hasn't worked and hasn't stabilized for a while, and it can just kind of go. So we see that quite a bit. And then when it comes to frozen shoulder or calcific tendinitis, unfortunately, we're going to see it more in female population.
Yes.
That's just kind of more common, usually older, over 40s.
Yeah.
It's, a thing that just kind of occurs. And so that's where we normally see
Get
it.
the short end of the stick a little bit for this, at least.
At least for this, yes.
Yeah. So kind of lots of different types of people coming in. So kind
it's
of
not just like a single type of person, and it comes from various different things.
And that's what makes them so common as well.
Yeah, absolutely.
Okay, let's start with frozen shoulder. So Oliver, can you explain to us like what frozen shoulder exactly is and like what's happening in the joint and what they mean by like freezing.
Yeah, so frozen shoulder is an inflammatory and fibrotic contracture of the shoulder capsule. The shoulder capsule, which is normally actually elastic and very accommodating, slowly becomes more inflamed, it thickens, and it actually constricts quite a bit, which then leads to limited range of motion in the shoulder. So when most people come to see us, they're usually experiencing a loss of range of motion along with pain in the shoulder that's getting progressively worse. Most people usually find that the pain gets worse at night when they're trying to sleep, and that kind of gets worse as it goes on throughout. A decrease in passive and active range of motion with frozen shoulder, traditionally more external rotation initially, and then after that kind of a few other like internal rotation as well. So yeah, that's what we normally see with frozen shoulder.
Yeah, it doesn't sound like it is a nice thing to experience.
No, it's not the nicest thing, and it can be quite debilitating for sure.
Yeah, like really, really limited range of motion.
Yeah.
So frozen shoulder tends to affect some people more than others, if I remember correctly.
Absolutely. Yeah.
So who would be more at risk, or like are there certain things that can maybe trigger it for people?
So yeah, what I've usually found with frozen shoulders, that it definitely affects women significantly more than it affects men. Although in my career I have experienced, or have encountered some men that do get frozen shoulder, but it's definitely very rare compared to women.
Yeah, predominantly for females, women.
And it's usually women over the age of 40, I tend to find. They tend to experience it quite a bit more. Diabetes is actually one of the biggest risk factors for frozen shoulder. That's been found over and over through the research, kind of showing that they do have a very high risk of frozen shoulder. Thyroid disease is also another reason people can encounter frozen shoulder.
Okay.
So that's quite common. And also if you've had any immobility of the shoulder, like if you haven't been moving it due to surgery, fracture, anything like that, that can also potentially lead to frozen shoulder for you.
I guess just like things tense up from that. That's
Exactly,
the idea behind it.
Things get inflamed and then the contractures begin and then kind of goes from there.
Okay. So frozen shoulder is known to go through a few stages. So there's a freezing stage, a frozen stage, and then a thawing stage. Right?
Yes.
Okay.
Yeah, 3 stages.
Can you walk us through like each stage or phase and like talking about what that feels like for the person and maybe like how long each one lasts?
Yeah, absolutely. So there's going to be, like you said, 3 stages going through. So the first one being the freezing stage. In that freezing stage, the main symptom that people are going to feel is basically pain. So they start to feel a lot of pain as the range of motion progressively gets worse. So they start to lose range of motion, but that main symptom is going to be pain. Most people usually experience it at night. That's when they kind of notice the pain more than any other time. So that's the first phase. The second stage is the frozen stage. And in that stage, the main symptom that people are going to encounter is the limited range of motion. So, in the freezing stage, it was progressively getting worse. And now in the frozen stage, it's pretty limited with most motions. External rotation, like we mentioned, is the initial one, but then all the other motions start to get affected as well. So then daily activities start to get quite difficult, reaching to pick things up, putting on a jacket, putting on your bra. It gets quite difficult to do that. Less pain through this period for sure, like there's almost no pain, but the limited range of motion is the thing that gets affected the most.
That's the biggest one.
Exactly.
You can't move your arm pretty much.
And then in the thawing stage, you're going to be seeing a progressive kind of return of the range of motion. So slowly it starts to move a bit more. So that's when we really like to hit it with some exercises to kind of increase the range slowly, get people back to moving, hopefully back to 100% as they were before. But what I have found in my career is that people with pre-existing conditions, such as diabetes, they tend to actually take longer to go through all the different stages. And so, instead of being like within that 1 to 3 year range, it can be, even longer. So I've seen some lead up to 5 years, 6 years, and take that long to fully recover.
5 years is a long time.
It is, yeah.
So it's good that maybe when they come in, you tell them that like, this is maybe the expectation.
Yeah, I think that's kind of one of the best things to do when you talk to someone, when you do diagnose them with frozen shoulder, just to let them know, like, these are the potential ranges, but it could also take much longer to get to full recovery.
Full recovery, yeah. Long process.
It's very long.
Not a nice one to be having.
No, absolutely not.
You have a patient coming in and you suspect that they may have frozen shoulder. Like, what does your assessment look like?
Yeah, so to assess for frozen shoulder, we definitely want to do a comprehensive shoulder exam, kind of go through everything from range of motion, orthopedic tests, and then determine what's actually going on with the shoulder. With the shoulder, as you probably know, there is quite a lot of orthopedic tests that go with it, just
Yes.
because there's so many different things that can affect the shoulder and so
Lots.
many different types of injuries that can happen.
Mhm.
But I would say the main thing that you determine when you're doing your range of motion testing is that you're actually seeing a decrease in both active and passive range of motion, which kind of leads you towards frozen shoulder.
Yeah.
Because what we normally find with any rotator cuff injuries is that they usually still have some passive range of motion available, as
Yeah.
where with frozen shoulder, you're going to lose both with the testing.
Yeah, I feel like that's like the main thing they taught us too. And like you said, in those certain ranges, right? You mentioned like external rotation.
Yeah, so
especially,
usually
too.
external rotation is usually one of the first ones to go. Then you're definitely going to see some abduction loss, and then flexion as well.
Yeah. And then aside from like in person, like do you think imaging is beneficial for this population, like an X-ray or even like ultrasound, MRI?
I think throughout my years, I've kind of determined that or found that it really doesn't help getting an MRI. So I know a lot of patients want to push towards getting an MRI. With the MRIs, what we normally see if we do get one is that there might be some thickening of the capsule in the MRI image, but that's not always quite visible depending on what stage they're actually in. So I tend to find that just through a good exam, you're usually able to diagnose frozen shoulder fairly well and differentiate it from, say, a rotator cuff injury.
Okay, which is nice for patients too. You don't really need to go and do extra imaging or like wait like 6 months to get results, right? You can be pretty confident in person.
Yeah,
what they have.
and then if they really want to know what could have potentially triggered it as well, probably some of the best things you can do is just get some labs and see if there is any diabetes going on, or if you have a thyroid issue that could potentially be contributing to the reason why you got frozen shoulder.
That's true. Yeah, you can go down that route too with like labs and stuff. So what does treatment look like for you when someone comes in with frozen shoulder, and does treatment differ based on what stage they're in?
Yeah, I think frozen shoulder treatment definitely depends on what stage the patient comes in with. So whether they're in the freezing, frozen, or thawing stage, you're really going to change how you're going to approach it and what you're going to do for that particular stage. So if someone comes in during the freezing stage, what we normally try to do is deal with the pain. So a lot of pain management, because that's going to be their primary symptom that they're dealing with. So some things that I find to be very helpful would be cold laser therapy during this time, because that definitely seems to help with the pain. Other things that we like to give them is just very light exercise and activities. So one of the exercises that I give a lot of people is the pendulums, where they basically just lean over gently. They can use just the weight of their arm initially to do some small circles going in one direction and then the other. If that starts to feel better, they can progress to slightly bigger circles or adding a small weight to help them out with that. So that really helps, because a lot of people want to stretch the capsule when they start to feel that tightening starting to happen. And that can actually make it worse. So you definitely want to try to avoid that. So it's more gentle motion, keeping it in a smaller range that they can actually deal with. And that's how we start with the freezing stage. In the frozen stage, then it gets a little different because we're just trying to manage, how much range of motion they actually have.
Work what they got, sort of.
Exactly. So we want to try to do some exercises to try to increase it gently and build up a bit more range, and just kind of keep some motion in the joint and in that joint capsule, so it doesn't completely freeze all the way through and seize up. Yeah, because once it seizes up, it can last longer. It can take a little longer to get through that phase or that stage. And then when we get to the thawing stage, then we basically want to start slowly increasing the aggression and how much range of motion we push in them. So, some more exercises to kind of really get more range out of the shoulder. We want to work around some of the tissues around the shoulder, try to open that up so we get a bit more motion out of the capsule and loosen it up as best we can, and kind of go from there.
Yeah. So very different kind of across the stages, and you really have to work well within those categories, I guess.
Absolutely. You got to just deal with what you got in front of you and go from there. And then just give them, let them know that it may take a little bit longer to get through each stage, depending on, what happened, anything that they had been doing that may have been wrong prior to doing that, like maybe stretching it too much in the initial stage.
Which I think we all would want to probably stretch it because you're like, oh, this makes sense.
Exactly. It feels tight, so I want to stretch it a bit more.
Yeah. So yes, definitely complex. Not an easy one to manage and to deal with.
No, it's definitely going to be a tougher one.
So obviously that's you on the chiropractic side. Is there benefit of maybe co-management? So referring to an RMT or acupuncture, any other healthcare professionals?
Absolutely. So, I find that massage can really help quite a bit for working on the surrounding muscles. So, working on the neck, the mid-back, around that particular area, getting into the pecs as well.
Yeah,
and trying to open things up a bit more and keep some motion in those areas while, you know, the shoulder's going through its different stages.
makes sense.
So that really helps out quite a bit. Acupuncture is also very good. It can help with the pain that the patient is dealing with, especially in the initial phase or the initial stage. They can make a big difference in helping decrease the pain that they're dealing with at that time.
Yeah.
And then for chiropractors that aren't probably good with exercises, that might not be their forte.
Yep.
You know, referral to a physiotherapist would be fantastic because they can
Yeah.
guide them through that.
Totally.
And all the different exercises for each stage that they're going to go through.
Yeah, so it can be a really like collaborative team effort. There's a lot of
Absolutely.
avenues of attack in a way.
Yeah. Okay, so we're going to move on to the rotator cuff and talk about the rotator cuff itself and then some of the injuries that can happen with the rotator cuff. So can you break down what the rotator cuff actually is and how it works?
Yeah. So I think most people don't know exactly what the rotator cuff means, but the rotator cuff is actually made up of 4 different muscles that kind of go around our shoulder, and their tendons are kind of what sit around and provide the cuff idea. So the cuff to kind of support, and their main purpose is to provide stability to our shoulder joint. They're actually not the main ones that are doing movement. They're more stabilizers. So make sure that our humerus, so this bone here, sits nicely in that socket I described before. So when we're moving, it stays nicely in the middle. So think of that golf ball being nicely on that tee, and that way it provides that stability. So that's like the main purpose of it. But because of that stability, it is very prone to injuries and can get strained a lot. And it's like super common for people to get injured and can cause a lot of grief with that too. And there's differences in like different types of people that get injuries to it too. So it can be injured one way versus another. But that's kind of the main idea. It's a stabilizer and kind of creates a cuff to keep it nicely there.
Yeah, so it helps with that really bad ball and socket joint.
Yes, yeah, exactly. Yeah. So that ball and socket joint that makes us move a bunch, that isn't really practical in that sense, but good for mobility.
Absolutely. So what are the different ways that the rotator cuff can get injured?
Yeah, so it can be like a strain because it's involving the tendons, and tendons have different degrees of how much they can be injured. So there can be like just a strain, as you call it, so like a slight overstretch is how I like to describe it.
Okay.
Then there can be tears, which can be partial tears or like full thickness tears. So I remember when I was younger, a physio described this actually really nicely to me with like your fingers being the fibers. So like a strain is like a little stretch, let's call it. Then your partial is like, you can have a small bit to almost like completely torn like that, and then full tear would be completely like that there, and like that partial rupture. Yeah, full rupture. So partial has a much greater variety in degrees from what I understood versus like the full tear. Okay. So that's like some example there. And then there's also, we call like more the degenerative injury, so something that happens but with more aging and like not using the tendons as well.
Yes. So as we mentioned earlier, shoulder injuries can happen with both athletes, but also people that are sedentary and just work at a computer all the time. Are those types of rotator cuff injuries the same, or are they going to be different?
Yeah, they'd be a little bit different, honestly. So for your athlete, overhead athlete, like we mentioned, pitchers, volleyball or the CrossFit, high rocks. Those are people who are doing a lot of the same things. So very repetitive patterns, also with like high load and demand. So those injuries are more from, like we said, repetitive patterns, and often because they're like pushing those tissues more than they're able to handle. So it's like overdoing it over a long period of time or a repetitive period of time. So that's like one type versus the people who are sitting more in their office and not doing as much. They have often more like degenerative changes, which come a little bit more with age, and it's more because they're not using those muscles like you kind of said before.
You have to move them.
Yeah, you have to move them. So then they're weak, and so when you do want to use them, they're just not strong enough to handle that. So they're kind of on opposite ends of the spectrum. One is like too much usage, and the other one's not enough.
Yeah. I know we may have mentioned a bit of this already, but is there a big difference when you assess for a rotator cuff injury versus frozen shoulder?
Yes, there are like different clues that we can pick up on through assessment and history. So like you mentioned before, like a shoulder that comes in, you're going to do a comprehensive shoulder exam, and there's a lot of the same things with it. But like the key one, like you mentioned before, with the rotator cuff issue, the person, when it comes to range of motion, will only really feel things or have an issue with active range of motion. Their passive will be okay. That will be the primary like difference between the two. And then, as well, we have a lot more orthopedic testing that we can apply to rotator cuff to like isolate maybe which muscle it is specifically,
Yeah.
but also we know that like knowing positive tests in a cluster really helps us be more confident with that diagnosis.
Absolutely.
So that's like, I would say the two main things with maybe our physical exam. And then when it comes to just like your history, which is part of the assessment, like people who come in with rotator cuff injuries will most likely have, an incident, like they were doing something overhead, felt something. There's a history of repetitive motions.
Yeah, like a shoulder press.
Yeah, shoulder press.
Spiking a volleyball.
Yeah.
That sort of thing.
All those things. So things that make you think about like they've used it versus like frozen shoulder that may not be as clear and like there's not like that acute incident that would make you think that way.
And it's probably progressing slower than say an acute injury that kind of just happened.
Yeah, exactly. So those are like the main things there, I would say.
Okay, perfect. When you do get a rotator cuff injury into the clinic, how do you treat it?
Yeah, so when someone comes in with a rotator cuff injury, there's a variety of things we can do here at the clinic. So one thing I like to pull is like using instrument-assisted soft tissue mobilization, so our tools for that. So, we're a scraping tool. It's really good for helping pain modulation and also improving range of motion in those structures.
Yep.
We can do also manual techniques with that, so like hands-on soft tissue release, or ART is another technique. Cupping can be used as well. So just all things to help manage the pain, help increase the range of motion, and help kind of promote that healing that we want to get into that area. K-tape is also really good to use.
Absolutely.
We love that, just taping up the shoulder, kind of giving that support, especially when people are in a lot of pain in the early stages, especially too. And
it definitely helps it move quite a bit better.
Yeah, I feel like it makes a huge difference. Some people don't understand it or don't believe it, but they put it on, they're like, wow, I feel like great, and they can move a lot more too.
Yeah, I think what I find is when patients take it off, they're often saying, oh, I felt much better when I had the tape on.
Yeah, it's when it comes off that the biggest difference is there. And then also, looking at structures around the shoulders, so looking at our neck and our mid-back, we know through some guidelines and research that's really helpful to keep those areas moving too, to influence the shoulder. And then, if someone's coming in with more of a long-term rotator cuff injury, Shockwave could even be beneficial for that, because it's known to be good for chronic tendinopathy. So that can be another asset we can use, but I don't really pull for that right away. That's like potentially much way down the line.
Me too. I usually save it for later on if it's not progressing the way I like, and then I
Yes.
can also add some Shockwave to it.
Yeah, but I feel like those other ones in the beginning and early stages are pretty helpful. And then,
Absolutely.
of course, rehab, right? Some exercises too.
Yeah.
Big ones. But yeah, that's sort of what it looks like for me.
Perfect. All right, Zoe, have you ever had any cases where people came in with a shoulder injury, where you were treating them pretty regularly, you just weren't finding that it was progressing the way you would like, and they ended up needing surgery for their shoulder?
I personally have not.
Okay.
However, I have heard of colleagues and other people who have had that happen. It is common, if you try conservative care, in-person stuff, and it's just not getting you the results, surgery can be an option. I find that when you really want to go down the surgical route, that's, for example, when, the conservative care is not going the direction that you want. And then also like the fact that the injury itself is really affecting their everyday activities, their ADLs, because it's so debilitating, then like surgery definitely is something to consider.
Yeah.
Another option too, we mentioned like those full thickness tears. If someone has a full thickness tear, that's probably more of a surgical route as well.
Yeah, I've had several cases myself where we were managing it, like it was maybe a potentially high grade 2 tear. And then as we kind of got some imaging done, either ultrasound or MRI, we definitely found out that they had a full thickness tear, and then they ended up having to get surgery to kind of help repair that. But it does happen quite a bit. The nice thing is that now we do have a diagnostic ultrasound, so I've definitely found a few of them where I said, I think this is probably fully ruptured, and you're going to have to go see someone to get that addressed.
Yeah, go get like an ortho consult and go from there. So
yeah.
It does happen, right?
It does, yeah. But it's just, shoulders.
Yes, it's shoulders. They're tricky.
They're tricky.
Let's move on to calcific tendinitis.
Okay.
So yeah, calcific tendinitis can be super painful.
It can, yeah.
Not a fun experience for people, I guess, that have it.
No.
Can you tell us more like what it is and what's actually happening in the tissues?
So calcific tendinitis is when you actually get calcium crystal deposits in the tendon. Traditionally for the shoulder, you're going to see it in the supraspinatus. That's going to be the most common area that you're going to find it. Yeah. But yeah, it can happen in other areas as well. Like some people do get it in their Achilles. I've also seen it in the glutes, unfortunately, even the biceps. So it can happen in other places as well. But, rotator cuff is one of the common areas that we encounter.
Yeah, very common and more common spot, correct?
Oh yeah, I think that would be the the more common area for sure.
Okay. And do we know like why it likes to migrate into tendons in the first place?
I think last I checked, they really don't know
Yeah.
the exact reason why it happens.
Okay.
But there's some theories on different things that can be causing it. But currently, there's no real
reason for
why
it.
it happens. Yeah, it just kind of occurs, and you just kind of have to deal with it. So Zoe, who tends to get calcific tendinitis?
Yeah. So I guess kind of similar to that of frozen shoulder, but for calcific tendinitis, it's usually women middle-aged and who are inactive, so sedentary. So it's actually not people who are doing more activity or thinking of your overhead workers or people who are using their shoulders more. They're actually not more likely to get
Which
this.
is kind of interesting, right? Because you think that they would be potentially at risk for this, but I guess not moving enough can also cause the issue.
Yeah. I think it's counterintuitive often for people, but so if you're, fortunately, as females, if you're middle-aged and a female and not doing a lot, this could be something that can happen to you more.
Yeah.
And then also a little bit related, if you have diabetes or thyroid issues, maybe a little bit more likely to get this too, on top of
very similar to frozen shoulder as well.
Yeah, exactly.
Yeah.
So kind of interesting, but that's how it goes for this one.
And so can it come on suddenly, or is it a slow progressing kind of condition?
Kind of a little bit of both. So the pain that people feel is super sudden, almost like they feel like it's overnight and you get this severe pain, can't sleep very well, but the process of it is actually a gradual buildup. So it's a gradual thing of like calcium being deposited into the tendons, and then really the sudden onset of pain is because our body's trying to break it down, and that's what we feel. So Oliver, if someone was to walk into the clinic, how would you diagnose them with having calcific tendinitis?
It's funny, is I actually had one of these cases this week. And so the way I kind of diagnosed this was, one, through the history. The person came in with a very quick, sudden onset of sharp pain in the shoulder without any history of injury. So they hadn't done anything for it to come on. It just kind of woke up and they were in a lot of pain. They were female. They were 40 plus and definitely sedentary. So that
check.
So that kind of hit those markers pretty easily. After that, we went through a shoulder assessment, made sure, checked everything out. But it still wasn't very conclusive of what was actually happening. And some of the findings were a little different. So I actually pulled out the ultrasound, had a look at the shoulder, could definitely see the calcium deposits in there.
Got to see them in there.
Yeah, absolutely. Now, ultrasound is actually not the best for this. So I then referred them out for an x-ray, which they got through their doctor. And that's where we actually saw the calcium deposits, which we kind of knew were there. But prior to that, I already started treating them. I did some cold laser for it, which definitely helped decrease some of the pain. And it was a pretty instant decrease of pain, which was quite nice.
Yeah, that's great.
And then taped them up, which also helped the shoulder and decrease some of the discomfort that they were dealing with at that time. So yeah, that's kind of how we do it.
Great, yeah. Nothing too different necessarily.
No.
And like you said, you kind of maybe some mixed signs from the assessment too. So
yeah, the assessment wasn't that clear, so that's why I decided to do an ultrasound on it and see what was going on in there.
And I think that history too kind of is what makes you think about it a bit more.
Yeah, they definitely ticked all the boxes right away.
Yes.
All right, so let's talk about treatment. I know there's lots of different ways that you can treat calcific tendinitis depending on the stage that they're in. But we do have Shockwave here at the clinic, and Shockwave is quite effective for treating calcific tendinitis. So can you walk us through that?
Yeah, totally. So like we've said probably before a bit, Shockwave is something that's very well documented in the literature for being beneficial for a lot of complaints, and calcific tendinitis is one of them. So really, I guess it's kind of doing two things. So number one, the Shockwave is helping to break down the calcium in the tendon itself. So you're getting that external stimulus through its actual like mechanical effects. So that boom, 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 boom.
Yeah.
So supporting the body's ability to do that. And then also Shockwave has been shown to help with stimulating tissue healing and accelerating that. So you're getting that as well. And that's really where the benefit comes from. And they say that patients can sometimes see pretty big changes in just a few sessions, especially depending where they're at with it. And it just helps them really accelerate their healing, because the body's trying to do it already, but this is just really giving that kickstart there.
Absolutely. Yeah, I've used it quite a bit for calcific tendinitis, and it's really effective. Like, people really see the results quite quickly, which is really good. Yeah,
so I think that one is a good tool to have to reach out to as well.
Yeah,
absolutely. Not very comfortable probably, but
no, it can be a bit rough at times, but it will have a lot of good benefits.
Yeah, so it's a great tool to have for us.
Yep.
All right, so Oliver, it's that time. We're into the rapid fire part of the segment, so let's get into it.
Okay, let's do it.
So first question, what is the most overused excuse patients give you for not doing their shoulder exercise?
That's an easy one. I don't have enough time.
Yep, I don't think there's anything else besides that.
No, pretty
don't have
straightforward.
time. Maybe like I forgot.
Oh yeah,
But
that happens a lot too.
yeah,
But yeah, I don't have time is one of the more common ones I encounter.
I would agree.
Okay, Zoe, what is one of your go-to rehab exercises for the shoulder?
You kind of mentioned this one already, but shoulder pendulum.
Okay, that's a great exercise, yeah.
It's a pretty good one. Maybe a second one would be like a TheraBand external rotation.
Okay,
Those are the other
depending on what's
depending
going
on what it is, But
Yeah.
I think pendulum's pretty even across the board, and that can be another common one to do. How about you?
For me, I think, depending on the situation, I do like sleeper exercises. I know some people don't, but sleeper exercise is pretty good. I've had pretty good success with those ones.
I think that was a good one.
And then obviously, my favorite cars. So
Yes, cars, yes.
either
yes.
scapulothoracic or shoulder cars,
Yes.
can be very effective for a lot of these shoulder injuries.
Mm-hmm. Yep, all of them are good. And then if you were to tell someone a piece of advice of what they could do to give your shoulder some love, what would it be?
I think we're going to get pretty repetitive with this one, but definitely move. That's going to be the key thing. Movement, exercise, and for everyone that's different. So it can be just something that you really enjoy and that you're willing to do consistently, because I think consistency is the key. So just do that more.
Yeah, I agree. I think that's like the best thing in general.
Yes. All right, Zoe. So what is an exercise that you've seen has contributed to a lot of shoulder injuries?
Oh, that's a good one. Yeah, I think like a big one is like an overhead weighted exercise. So overhead press, even people doing like cleans and jerks. Yeah, that would be my big one.
Yeah, I think for me from CrossFit, I think those are great exercises to do.
Yeah, don't avoid them, but
don't avoid them. But I think people just load them too quickly, and then they end up getting injured. So me as a chiropractor, I've often had to put on what I call my chiropractic blinders on, just to keep on as I'm at the gym. Don't look. Yeah, because otherwise, I'll be handing out cards all over the place. But
come see me later.
Exactly. But yeah, that's probably a good one.
Big one there. Yeah.
So thanks again for joining us for another episode. We appreciate you being here. This is BodyPlus. Know more, move better.